I am Courtney. I am your UW outpatient chief, and this morning I'm going to be talking to you about low back pain. You are welcome to ask questions throughout this. Feel free to use the chat. I'll do my best to try to look and see if there's questions that pop up in the chat while I'm talking. But we're going to get started talking about low back pain. So I have no disclosures. And the objectives of today's talks, we are going to talk about how to evaluate acute low back pain whenever patients come into clinic with this chief complaint. We're also going to talk about the role of advanced imaging and workup and evaluation of low back pain, and then learn about some of the non-pharmacologic and pharmacologic management of low back pain, both talking about acute and chronic low back pain. So why should you care about low back pain? Because it is super, super common. You will see it if you haven't already seen it in clinic. It is one of the most common chief complaints. I've read in the literature anywhere from the second most common in primary care clinics to the fifth, but it's somewhere in the top 5 to 10. So something you will certainly see. And many of the people on this Zoom call, myself included, have had low back pain at some point in their life. Yep, I'm seeing some hands raised. And it's estimated that up to 80% of the US population will experience low back pain at least once in their lifetime. So something that might personally affect you, but also definitely the patients that you're going to be seeing. And it can really limit a patient's function and quality of life. Again, if you have ever had back pain or twisted your back before, you know how much it really, really stinks and can be really limiting to just all of your daily activities. And it's really, really expensive too within our US healthcare system. How expensive, you might ask? So there was a study published in JAMA a couple of years ago that looked at US healthcare spending from 1996 to 2013, really trying to group by major medical conditions and to see what the associated costs were. Low back pain was lumped in with neck pain, and so a common musculoskeletal complaint, but estimated an upward of $87 billion. That is a lot of money. A lot of those costs are associated with indirect costs, so lost wages and productivity, but you will see that it's something that we should care about. And so let's start with the case to get us into things. So Mr. Adams, he is a previously healthy 46-year-old man who presents to clinic with a 4-day history of low back pain. He tells you he developed intense back spasms and back pain with spasms over the weekend after he helped his friend move into a new apartment. The pain is localized to the right side of his lower back. It's really severe whenever he turns and twists his torso. He comes into clinic today because he just cannot tolerate the pain any longer. He says, "Doc, I am miserable." And so let's talk about what we should be thinking about in the differential and how to focus our history and exam whenever we're seeing somebody who is coming into clinic with acute low back pain. Maybe not surprising to you, the most common cause of low back pain is mechanical etiologies. And over 80% of the time, people coming in with acute low back pain are going to have non-specific low back pain. But some of the most common etiologies that you'll see, I've listed here in the box, a lot of them are related to lumbar strain or sprain. There can be disc problems, herniation. You can have osteoporotic compression fractures. Again, this comes with the group of patients that you're going to be seeing by demographic, might help you shift your differential. There are also plenty of non-mechanical causes of low back pain. People who have any sort of history of malignancy or concern with malignancy. You should be thinking about metastatic disease as well. The most common cancers that will metastasize to bone are prostate, lung, breast, and kidney. Those are the most common ones you should be thinking of. Multiple myeloma, again, would be something else to be thinking about as well. Ankylosing spondylitis, and then certainly infectious etiologies as a cause of back pain, and certainly something that you do not want to miss. An epidural abscess, which we'll talk about a little bit more in a few slides, is a do not miss diagnosis with this chief complaint. There are also some extraspinal causes that are musculoskeletal related that can cause low back pain. Hip osteoarthritis, people might have referred pain or discomfort in their low back. I will say with hip OA too, people will often have groin pain. And then thinking about some things that are not necessarily related to the musculoskeletal system, we have to be thinking about the abdomen and in the retroperitoneal space. So a AAA or an aortic dissection, pyelo, you guys can see all of the things on this list, nephrolithiasis. Don't forget about the GU organs as well. And then I put skin stuff on there. You'll be looking at the skin whenever you're doing an exam, but don't forget that that can cause pain as well. So what are some red flags? Whenever a patient's coming into clinic, you are taking their history, you are doing a review of systems. We have all heard about these red flags that exist with back pain, but specifically the things that you should be worried about whenever you are talking to a patient about their low back pain are things like any neurologic deficits. So urinary retention or incontinence, new fecal incontinence, saddle anesthesia. The language that I use whenever I'm asking a patient about saddle anesthesia, I will say, do you feel the toilet paper whenever you wipe? Because that's an easy way for them to quantify if there is something abnormal for them. The traditional teaching for patients who are having any sort of red flag system is that you should order early imaging and maybe dive into a more extensive workup for their back pain. And I will say a lot of that will come with your clinical gestalt about what you're most concerned about and how much of a workup you want to do. But you should also be concerned about patients who are coming in with acute low back pain and populations who are at high risk for infection. So that's any of our patients who are immunosuppressed, people who are on hemodialysis, right? They have this risk of transient bacteremia, or certainly bacteremia from how often their fistulas are being accessed for hemodialysis. Anyone who has had a recent invasive epidural or spinal procedure, someone who has current or recent injection drug use, that concern with maybe an epidural abscess forming if there's any transient bacteremia from their injection drug use. Someone who's had significant trauma related to their age. So I worry about somebody who's coming in with low back pain, someone who's had a car accident or a fall in an elderly person who might have osteoporosis. You're worried about a compression fracture with that. Anyone has other signs and symptoms of any sort of infection, so someone who's coming in with objective fevers. And again, I mentioned malignancy, you should be thinking about breast, prostate, lung, kidney, and multiple myeloma. What about some yellow flags? So we don't necessarily talk about the yellow flags as much, but yellow flags basically mean patients who are at risk for greater chronic disability. And these have been studied and looked at to been shown that they're associated with more poor outcomes. So it might be a patient who is really fearful or avoidant of activities, right? They won't get out of bed because they're really afraid that it's going to make their back pain worse. People who have a history of psychiatric illness, someone who has had multiple episodes of back pain or various musculoskeletal pain complaints in the past, or people who are coming in with maybe maladaptive beliefs about pain, that this is never going to get better no matter what you do, or that invasive treatment is the only way that they're going to get better. So if we go back to our case, so again, Mr. Adams, he is our previously healthy 46-year-old man who's coming in with this 4-day history of low back pain. After you gather some additional history, you learn that he has no weakness or numbness in his lower extremities. He denies any urinary or bowel habit changes, no fevers. I made it pretty easy to tell you that his otherwise review of system is negative. He's got no past medical history, doesn't take any meds, he is housed, no alcohol, tobacco, recreational drug use. And so now let's talk about the physical exam. So right, with every chief complaint that someone is coming into clinic with, you should be thinking about a focused physical exam for them and what are going to be the most pertinent things that you are going to perform whenever you are seeing this patient in clinic. So the first thing, like with many physical exams, is going to be an inspection, right? So you're going to have them lift up their shirt depending on where the level of their pain is. You're going to look at any evidence of trauma, look at their skin. You could be looking at spinal alignment as well to see if there's any scoliosis or hyperkyphosis. Palpating is the next step, so specifically palpating the paraspinal muscles to see if there's any tenderness, also palpating along the spinous processes to see if there's any focal tenderness along their vertebral column or any step-offs that you can feel. A focused neurological exam as well, right? You don't necessarily have to do cranial nerves for somebody who's coming in with low back pain, but you should be assessing strength in all of their muscle groups in their lower extremities, testing sensation, looking at reflexes, and then looking at their gait as well. And I think it's really important to just watch how a person walks to the exam table. I think that that can tell you a lot, right? And someone who is previously healthy, a young person who can barely get out of the chair and walk themselves to the exam table, makes me worried about the pain that they're having, you know, more so than someone who can like hop up and skip over to the exam table. And then on the next slide, I'll talk a little bit more about the straight leg raise test and the crossed straight leg raise test. And then other, I will say that this is going to be guided by the history that you're taking, right? If you think they're having some groin pain as well, they have known osteoarthritis in their hip, you might be doing a focused hip exam, or looking at any sort of abdominal pathologies, checking for, if you're worried about pyelonephritis, you're checking for CVA tenderness. You may want to do a pelvic exam depending on the complaints that they have. So let's talk about the straight leg raise test and the crossed straight leg raise test. And essentially, these are tests that we do to see if there is any radicular component to their pain. And by radicular, I mean a nerve-like pain. That's the shooting sensation that they describe to you that they feel running down their leg that's associated with their pain. So with the straight leg raise test, it is essentially the patient is laying supine and the examiner will raise the leg up, extend it on the symptomatic side first, keeping the foot dorsiflexed. I tried to pick some sort of a figure that would show this as best. The really important aspect of this is to be really careful that the patient is not helping you lift their leg up. So I will say to the patient, give me all of the weight of your leg. Be a rag doll, because if they're using and engaging some of their muscle groups, it might not give you a true assessment of if they're having any sort of radiculopathy, right? The idea of this is that it places some increased tension, some dural tension on the low lumbar and high sacral laterals, that if there is a nerve root impingement or any sort of nerve involvement, this is maybe going to bring out those symptoms. A positive straight leg raise test is whenever a person experiences radicular symptoms. So again, that's that shooting pain that they feel down their leg on the same leg that is being raised. So if the patient in the figure says, yes, doc, in that leg that you are raising, I am feeling shooting pain, that is a positive test. If someone tells you, ooh, my hamstrings feel really tight, or my back pain is getting worse, that is not a positive test. The positive test is only if there's radicular symptoms. The straight leg raise test is pretty sensitive. It's got a 91% sensitivity, but it is not very specific. As you'll see, it has a 26% specificity. The crossed or contralateral straight leg raise test is essentially the same exact exam, but you're looking for symptoms in the opposite side. So for this example with this figure, this is looking at the right leg in the patient that's laying down on the exam table. The specificity for the crossed straight leg raise test is actually much better. It's 88 to 90% specific on the other opposite side of on the opposite leg than that is being raised for nerve root impingement. Okay, so we go back to our patient, back to Mr. Adams. I put his vitals there. They are all normal. His exam, as you will see, I have only written one thing in red, so that is the only thing that is abnormal. But his musculoskeletal exam is significant, really just for tenderness to palpation of his right lumbar paraspinal muscles. He's got no tenderness or any step-offs along his spinous processes. You did the negative straight and crossed straight leg raise test. Bilaterally, that was negative. His skin and neuro exams are all within normal limits. So he walks back to the chair and then he asks you, what's the plan? But before you can dive into the plan, he says, but my brother said that I need an MRI. I have to have an MRI. I think it's important to call out that many patients who are coming into clinic with a chief complaint of low back pain might expect that imaging is going to be ordered, but it's actually not indicated or needed in an overwhelming majority of cases with this chief complaint. There's actually been some studies that have looked at this, right? If you jump to imaging with patients, what are the outcomes? There is no associated improved outcomes with early imaging in patients who have non-specific low back pain without a clear indication, right? Think about those red flags. It can lead to, not surprisingly, higher costs if you're ordering imaging studies or unwarranted surgical or invasive treatments, right? Sometimes we order imaging and it shows us something that is abnormal, but it might not actually be the cause of what is causing the pain or the problem for patients, but that's the thing that we see on imaging, and so that's the thing that we go after, and that is maybe not appropriate in a lot of patients who are coming in with this chief complaint. And there's actually been a joint statement that has come out by ACP and the American Pain Society that both explicitly recommend that clinicians should not routinely order imaging or other diagnostic tests, do some big workup in patients who are having non-specific low back pain. So who exactly gets the low back pain, right? This is what I was mentioning. You should be thinking about those red flags, but generally speaking, it's pretty rare whenever people are coming into clinic that you're gonna jump to getting early imaging for their low back pain. but you might be thinking about it in several clinical situations. I put a couple of these on here. If someone is having progressive neurologic deficits or any sort of signs of cauda equina syndrome, so urinary retention, fecal incontinence, new saddle anesthesia, that is when you should be jumping to an emergent MRI and having neurosurgery evaluate the patient, right? You might be sending them to the emergency department to have these things happen. Or if it's somebody who you have a high suspicion for clinical infection, right? This is someone who you're seeing in clinic who's coming in with fevers at home. They are immunosuppressed. They recently had a transplant and they've got some point tenderness along their spine. You should also be thinking about an MRI and an infectious workup earlier in this patient than you would be without some of those other risk factors or review of systems. But he says, "Doc, you are not listening to me. I need imaging." And so the key part of this, and I think this is really, really tricky. I can put counseling and reassurance in bold and with an exclamation point, and that only goes so far. But some tangible tips that I have whenever you're navigating this conversation with patients, which I promise you will if you have not already, is providing some commentary about reassuring findings whenever you're performing their physical exam. So this doesn't have to be for every single step of the way, but maybe while you're checking their strength, say you have full normal strength in your legs and every muscle group that I tested. That is reassuring to me that this is maybe not related to some nerve injury, right? Giving them a little bit of guidance about what you're looking for, what you're checking for, because that's what they're worried about. And acknowledging what we already talked about, that incidental findings on advanced imaging are really common and they can lead sometimes to unnecessary tests and interventions for patients. And then talk to the patient about the fact that it's really unlikely that they have a serious underlying condition. I'll share on a couple slides from now what the natural history of nonspecific low back pain is, and the high percentage of patients who are actually going to have spontaneous resolution of their pain. But again, the patients that are coming in with those red flag symptoms and something that is a really serious etiology of their back pain is really, really low. But it's really important to acknowledge how much it sucks, right? It is really uncomfortable, really distressing. And I think that that can go a long way, is just getting on the patient's level to say, this is really terrible. I hope that we can find something to make you feel a little bit more comfortable and keep you functional, and that this is going to improve. And then also leaving the door open for reevaluation, right? Medicine is humbling. Sometimes things can change when you see them in clinic, and 2 days later, they might develop some more worrisome symptoms. So making a plan with the patient to please check in if something changes with how you're feeling and have contingency plans in place. But also let them come back to clinic and say, hey, in 4 to 6 weeks, you're welcome to come back and we can reevaluate the plan that we put in place and check in how you're feeling. All right, so now you have decided that he likely has some lumbar strain related to lifting those heavy boxes. You have counseled him about the fact that he doesn't need imaging of his spine, and he bought it. And so what are some of the management recommendations that you are going to be providing to Mr. Adams? So again, the goal of treatment of low back pain is to really maintain function and improve a patient's pain complaints. Now, fortunately for all of us, there is a clinical guideline that has been put out by ACP about both acute, subacute, and chronic low back pain, some guidance on non-pharmacologic and pharmacologic interventions to consider. And so these guidelines are really focused on, for acute low back pain, the fact that most of the time patients are going to improve regardless of what you recommend. And so you should really lean on non-pharmacologic treatments first. I said I would mention what the natural history of low back pain is, but to give you some actual numbers and data, 50 to 75% of patients who are coming in with non-specific low back pain will have a spontaneous recovery at 4 weeks. And that number reaches over 90% at 6 weeks. And it's really going to be regardless of what you do. You can give them a full list of things or give them just some general precautions and a couple of recommendations, and they're probably going to get better in 4 to 6 weeks, which is great. But also that feels like a really long time for patients. And so what are the things that you can recommend in the middle so that the next 4 to 6 weeks are not completely miserable for them? And so some of the things that have been pulled out of the ACP clinical guidelines that I put on this slide and what the evidence is behind it. So there is moderate quality evidence for heat that says that superficial heat will improve pain relief for patients and disability compared to placebo. And so that is an easy thing to recommend. Alongside that, I always make recommendations. I think about ways that patients could harm themselves, even with very easy recommendations that I'm making for people. Tell people to put a t-shirt or a towel between whatever really hot thing is. I don't want them burning their skin. You'd think that I don't have to say that, but I do. Some other things that you should consider. So exercise or physical therapy, right? Like my instinct is to think PT is great for everything. PT is the fix for everything. But what is the actual evidence behind patients who have acute pain? So it's not necessarily PT will be helpful for people whose pain is going to resolve spontaneously in 4 weeks, but this should be the patients who maybe have those yellow flags, who are at risk of developing higher rates of chronic low back pain or chronic disability, that you should be thinking about putting in an early referral for them. And there is plenty of evidence to say that PT is really helpful in subacute and chronic back pain. Then some other things to consider: massage therapy can be helpful. There's some low quality evidence to say that there's some short-term improvement in pain and function, and patients like getting massages. It is an actual order that you can put in a referral. There is some variability with insurance coverage, with massage therapy. So tell your patients that up front if they are coming in requesting massage therapy. And acupuncture, same thing. There's some low quality evidence. Something that I didn't put on this slide, spinal manipulation or going to a chiropractor. I have had plenty of patients ask me about that. There's some, similar to a lot of the other things on the slide, some low quality evidence that for non-specific low back pain, it can be helpful with pain and function in the short term. I always tell patients the caveat that I will never recommend manipulation of the cervical spine, right? There is real risk and real cases of people who have died or had great harms done by cervical manipulation. They can have shearing or dissections of the vertebral arteries. But I mean, in my limited experience, I think that low back pain and someone going to a chiropractor for their low back pain is probably less harmful. But again, I will caution patients against doing any sort of cervical manipulation. Something else to recommend are some self-help materials or some written materials. There are a lot of internet-based guidelines. The back book is one that you can Google. It's also on the up-to-date article for people with acute low back pain. And it basically just gives patients a little bit more tools that they can take home, reading materials, some exercises that they can do at home. And there have been some randomized controlled trials that have looked at these self-care education books and that they have been helpful for some patients. And so it's an easy thing and a safe thing to recommend. And then what about activity recommendations, right? How active are you going to tell your patients to be whenever they're coming in with this complaint? So the key thing is to avoid bed rest. Bed rest has been associated, there is moderate quality evidence to say that people have more pain and a slower recovery compared to those patients who are ambulatory, walking around, still trying to do their normal activities. So I would say to encourage your patients to really resume their usual activities as much as they can tolerate it and avoid periods where they're really inactive. Recommendations about when they should return to work should be really individualized based on the work that they do, right? If someone does heavy lifting all day long and just hurt their back heavy lifting, I'm probably not going to recommend that they go back and do their normal work activities the next day. And so maybe they can take a couple of weeks to do something more desk-based or office-based, making sure that they're still getting up and walking around. But that should be individualized based on the patient that you're seeing. Now let's talk about some medications. What actually has evidence behind it? So for acute low back pain, the first line medication that is supported by evidence are NSAIDs. The key is to just recommend a short course, right? I do not recommend that people stay on ibuprofen for the rest of their life, but I do recommend it for about a week, that they should try it for their low back pain. You should have some pause before you make this recommendation and are prescribing it to patients. People who have a history of significant GI bleeds, I am not recommending that they take NSAIDs. The same thing with people who have a significant cardiovascular history. There have been plenty of, or at least one good study in the last couple of years that has looked at NSAIDs and different types of NSAIDs and what the associated adverse cardiovascular events are. And there's real harm for patients who have a significant cardiovascular history. And then patients who have any sort of renal dysfunction, advancing CKD. And then what about Tylenol, right? We think about Tylenol all the time. It's an easy thing to recommend. You give it to everybody in the hospital who's having any sort of pain. But what's the evidence about acute low back pain and Tylenol? It's not great. This was actually historically what people leaned on as first line and what the general consensus was until there was a 2016 Cochrane review that came out that found that acetaminophen had really no benefit in treatment of acute low back pain over placebo. And that was a big kind of shift in an approach in how people were treating patients with acute low back pain. But I will consider it and reach for it in patients who have contraindications to other medications, right? If I have an 80-year-old who has stage 4 CKD and has 3 stents, I'm not recommending Tylenol. I'm not recommending NSAIDs, sorry. I am recommending acetaminophen because that's an easy thing for me to recommend and pretty low harm, so long as people are staying below the recommended dosage for in a 24-hour period. Some second line medications and things that you might see that patients are prescribed whenever they're coming in for acute low back pain or that you should be thinking about. Muscle relaxers. So I think about this in patients who are having functionally limiting acute low back pain, especially if they're giving me some history that makes me think about there being a spastic component. Again, this will be a short course. I'll prescribe this depending on the patient, depending on how intense their spasms, what they do, right? Some of that is individualized, but I will give patients a five-day course of some muscle relaxers to take PRN. The side effects to know about, many of them can be anticholinergic. They can have sedating effects. I think specifically to give you some muscle relaxers that I reach for first. So I think of cyclobenzaprine or Flexeril. Methocarbamol are probably the two that I reach for more than any, but there is a long list of muscle relaxers that you can try. But I think that those are generally the first line ones that I will reach for. And then what about opioids? What about tramadol, a weak opioid? So there is some consideration that a short course could be helpful for a patient who has really failed every other option that you have recommended, and they have severe intense pain that is limiting their activity. But the evidence to support it should be really limited, and you should really not be thinking about this as first line for patients who are coming in with acute low back pain. The 2016 CDC recommendation on this issue is that if opioids are going to be used for low back pain, you should limit it to less than 3 days. But I will tell you in my personal practice, this is not something that I am prescribing to patients coming in with this chief complaint. And then some medications that have really limited or no supporting evidence for, again, this is acute low back pain. Antidepressants, I'll talk about in a minute. They are things that should be considered for patients who maybe have subacute or chronic low back pain, but they're really less helpful for acute low back pain, right? If we're thinking about like an SNRI, like duloxetine to help a patient who is having back pain, it's going to take a little while for that to maybe be effective. And who knows, they might fall in that window of 4 weeks where 75% of them are going to have spontaneous resolution of their pain anyway, and there's probably not enough time to let them be effective. And then systemic glucocorticoids, I will say that there are different practice patterns that I have seen patients who receive a short steroid course. There's moderate quality evidence to say that there's no differences in pain when it comes to steroids versus placebo and no effect on functions. And this is really specific for patients who are having radicular low back pain, right? The idea is that if there is some nerve root impingement, there is some inflammation, NOS, that is happening around the site of that impingement. And so could steroids be helpful for that? I'll even tell you that the up-to-date article that talks about steroids in use of radicular low back pain has some differences of opinion within the writers of the article. I don't remember the exact language. I should have looked at it prior to this, but there's something in like 2 of us who wrote this don't use steroids based on the moderate quality evidence that exists, and 1 of us still will consider a short course. So that's to say there's really not evidence to support it, but you might see some differences in practice patterns. And then just to talk a little bit about chronic low back pain, I'll share this case as Ms. Smith. She's a 63-year-old woman who comes to clinic for evaluation of low back pain. She's been dealing with her pain for over 10 years. That hasn't changed recently, but her pain is keeping her from gardening. She describes the pain as a deep ache. She occasionally takes acetaminophen with minimal benefit. Her medical history is significant hypothyroidism and hypertension, for which she takes levothyroxine and chlorthalidone, respectively. She's had no surgeries on her back. Her vitals and physical exam are largely unremarkable. And so, what are you going to recommend for Ms. Smith's chronic low back pain? And a lot of the things are still the same as acute low back pain, but there are some differences in the exercises and activities that have evidence to support it that some of you might have heard of, but you should really be leaning on non-pharmacologic options for treatment of chronic low back pain. The things that have evidence behind them are exercise, Tai Chi, yoga, motor control exercise, which I will say was something I was not familiar with and have not routinely recommended to patients. But it is this idea, or MCE is how it's listed in a lot of resources. It's exercises that focus on restoring coordination, control, and strengths of the muscles. And so I think it is exercises that focus on activation of some of the deep trunk muscles and target some relaxation for patients. CBT also has some evidence, and mindfulness-based stress reduction as well. What's in your pharmacologic toolkit? So NSAIDs, maybe on a PRN basis, right? This is someone who might be having an acute flare of their chronic low back pain. Again, I am not prescribing ibuprofen for somebody for the long term. Again, you should be cautious about who you're recommending NSAIDs for. And some second line options that have some evidence behind them, duloxetine and SNRI, like I mentioned earlier, tramadol as well. And what about surgery? So I will say that I was hoping to do a slide on surgery, and the data is pretty mixed, and I think it really depends on what procedures patients are having. Most commonly, patients who are coming in with chronic non-specific low back pain seeking surgery, the most common procedure that people will get is a vertebral fusion. So a surgery that will fuse two or more vertebral discs together. The idea is that it's restricting some of the spinal motion, and you're removing a degenerative disc that might be the source of a patient's pain. There's been several studies to look at least for fusion surgeries. Do people have better outcomes related to pain and function versus people who choose a less intensive or invasive strategy for their pain? And I will say that what I read at least is that there's not great differences in outcomes for patients. And so if people are asking you about surgery, right, you should still be leaning towards trying all of the things in your non-pharmacologic and pharmacologic toolkits, but it's a shared decision making, and know that there's not clear evidence to say that like surgery fixes everything for everybody. And then what about opioids? So this is an important study that I want to share with you guys that came out while I was in residency, published in JAMA. This was a study that looked at chronic pain in a veteran population. And the question was for patients with moderate to severe chronic back pain, and this also included hip and knee pain related to osteoarthritis. Do opioids help their pain-related function compared to non-opioid medications? And so there were 240 patients enrolled in this study. They were involved in VA primary care clinics. Again, they're looking at opioids versus non-opioid therapies for patients with back, knee, hip osteoarthritis. And not surprisingly, what they found was no. Opioids were not helpful in this patient population. They did not have a significant difference in pain-related function at a 12-month follow-up period. And the follow-up rates were very good in the study too, versus non-opioid therapies. And so this is a conversation I will tell you that you will navigate in clinic. This is something that we have to have conversations with patients about, or maybe you're taking care of somebody who's been on opioids for years and years and years with their pain. I want this so that you guys know what the recent evidence behind opioids related to chronic pain-related function is. And so some of the take-home points, back pain is really common. You will see it, I promise. If you haven't seen it already in your first week of immersion, you might see it this afternoon. Most of the time, patients' pain is due to non-specific musculoskeletal etiologies, and most of the time, it is going to resolve without treatment. Majority of patients do not need advanced imaging, but you should be thinking about those red flags and those yellow flags for people that you might want to consider doing an earlier workup rather than watchful waiting for several weeks. But generally, you should avoid prescribing costly and potentially harmful treatments. that is both with medications and with sort of more intensive and invasive treatments, and really lean on your non-pharmacologic options and short courses of medications for patients. I will pause there, and I think I finished a little bit early. What questions does anybody have?
I have a question about the surgery thing that you were mentioning. So is the surgery for people who have sort of undiagnosed, non-specific chronic back pain?
Yes, so there are patients who have come into clinic with years and years of chronic low back pain and get referred to surgery centers and to try to see if surgery is an option to fix their pain. And again, I think what I was reading about at the Waters are pretty muddy on specific indications, what the specific outcomes are. And so it's not a decision that I or you are making necessarily in clinic.
I mean, are we obligated to do any sort of workup prior to, like, if the patient is very insistent on being considered for surgery, do we then go down the route of like MRI?
Yeah, great question. I normally don't. I will defer that to the surgeon because I think that sometimes they want specific imaging if they're worried about something specific. And so I might send, if a patient really wants to be referred to be evaluated, I'm not an expert in that area, and so I will place the referral, but I don't do any of the imaging workup. I will let the surgeon dictate, one, if that's appropriate for the patient, and two, what exactly should be done. Great question. Thank you for asking, Kim.
I have seen some patients who had a spinal stimulator in, and I wonder what the evidence behind that is.
I don't know. A great question. I'm sure that there is evidence that exists one way or another, but I don't know that data specifically.
I'm sorry if you already mentioned this, but can you talk a little bit about topical creams?
Oh yeah, thank you.
And patches.
Yes, so the ACP guideline does talk about topical therapies for patients. Thank you for bringing that up. I meant to mention it. There's some evidence that capsaicin topically can be helpful for patients with acute low back pain. The evidence that lidocaine patches, there's really no evidence to support that they're helpful in acute low back pain. They're an easy thing to grab, certainly in the hospital for people, and I think they're pretty low harm to do so, but the evidence doesn't necessarily support it for acute low back pain. And the thing to know about lidocaine patches too, you guys might already run into this either in clinic or in the hospital. Insurance coverage of lidocaine patches differs essentially, but a lot of times people are paying out of pocket for those. And so that's something to consider if you're saying this is an easy, not very harmful thing to recommend. It could be costly.
So with regards to like capsaicin, what's your opinion about that versus diclofenac gel? I've had a couple of patients that have come into clinic and I've recommended capsaicin, but everybody seems to be gun-ho about diclofenac gel.
Yeah, I think my practice is probably to try diclofenac first. Capsaicin, I've just had a number of patients who have not liked necessarily the burning sensation that it gives them, or they're like really worried about it being on their fingertips and touching their eyes. And so diclofenac gel is another easy one to recommend for patients. And if the idea is that NSAIDs are the first line, can topical NSAIDs be helpful? Again, there's not that great of evidence to say that topical therapies are helpful, at least related to lidocaine patches and things, but I think diclofenac is a great thing to try too.
And that can be used, go ahead.
No, go for it, Kim.
I was just going to ask, that can be used in people with a history of renal insufficiency.
Yes, there's some absorption of topical NSAIDs with diclofenac. It is much less than systemic absorption from people taking NSAIDs orally. And so if people have a GFR of 14, like I'm doing everything to avoid anything to make their kidney function worse. And so it's a little bit of your discretion about how advanced their CKD is. Know that there's some absorption, but it's much less than oral NSAIDs.
as far as lidocaine patches go, I believe that they do make like a generic form that might be like less like strength. Is that correct?
Yeah, there's a 4% and a 5%. The 5% is really never covered by insurance. The 4% I think has some variability. And so it might just be a patient needs to make a phone call to the pharmacy to see what they're covered. But yeah, there are two strengths of them.
And the 4% in your experience still works, I imagine, just as well.
I haven't noticed the difference between the two, but I also haven't done a like little trial of it or anything. Yeah, but 4% is what I will use for patients for a variety of things. Great. Well, thanks, guys. I'll hang around for a minute if anyone else has any questions or in the chat.